Welcome to KJR SummaryCast, audio summaries of peer-reviewed articles published in the Korean Journal of Radiology. Designed to enhance reader convenience and the overall KJR experience, SummaryCast provides conversational audio overviews for time-constrained listeners and mobile-friendly learning. This recording was created using a combination of AI tools with oversight from the KJR editorial team or the article's authors, including necessary edits and corrections. For the most accurate and complete information, we encourage you to also read the original published article.
Welcome to SummaryCast. Today we're looking at a paper designed to bring some clarity to a common but often ambiguous finding.
We are. The paper is Radiological Approach to Splenomegaly, Etiologies, Pathophysiologies, and Diagnostic Strategies. It's a review article from the latest issue of the Korean Journal of Radiology, published in February of 2026.
The authors call the spleen the silent and forgotten organ, which feels about right. Splenomegaly shows up constantly on reports, but it's often just listed as a descriptive finding without much more to go on.
And that's the core problem this paper tackles. Splenomegaly is almost always secondary to some other systemic disease. So when a radiologist identifies it, it's not the end of the diagnosis, it's the beginning of an investigation.
Okay, so let's start with the absolute basics. How is splenomegaly even defined? There's a standard number that gets thrown around.
There is. The classic upper limit of normal for splenic length is 12 centimeters, but the authors immediately highlight how problematic that simple cutoff is.
How so?
They cite a key study by Chow and colleagues, which found that splenic size correlates strongly with a person's height, weight, and sex. It tends to be larger in males and in taller, heavier individuals.
So a one-size-fits-all number is bound to be wrong for a lot of people.
Exactly. In that study, 26% of otherwise healthy males and 6% of females had a spleen longer than 12 centimeters. Following that simple rule would trigger a lot of unnecessary workups.
That's a significant false positive rate. What's the alternative then? More personalized thresholds?
Precisely. The paper points toward newer, validated algorithms. There's even an app mentioned, Splenocalc, which determines percentiles for splenic size based on those individual factors. And, of course, automated deep learning tools for splenic segmentation are making volumetric analysis much more feasible and accurate.
Got it. So step one is to be more nuanced about what actually constitutes enlargement. Let's say you've confidently identified splenomegaly. What are the go-to tools for figuring out why it's enlarged?
Well, the review covers the whole spectrum of modalities. Ultrasound is the most validated for pure size measurement, but CT and MRI are obviously crucial for evaluating the splenic parenchyma and surrounding anatomy.
What about differentiating benign from malignant causes? That seems like a critical decision point.
It is. And for that, the paper points to a meta-analysis showing PET-CT has the highest accuracy, at around 92%. It's become a primary modality for staging lymphoma, for instance, because of its sensitivity for both nodal and extranodal disease.
Okay, but what if PET isn't available, or the findings are still ambiguous? That brings up the topic of splenic biopsy.
Right, which has traditionally been avoided due to bleeding risks.
It was seen as a major contraindication. Has that changed?
The paper argues that it has. With modern image guidance, percutaneous core needle biopsy of the spleen is now considered much safer. Recent studies show complication rates are generally under 10%, with major complications being quite rare, around 1% to 2%.
That's a non-trivial shift in practice. It opens up a new diagnostic pathway, especially for suspected lymphoma that just presents as diffuse splenomegaly without a discrete mass.
You nailed it. It's another tool in the toolbox. And that really leads us to the main contribution of this paper, a systematic framework for thinking through the causes of splenomegaly, categorized by pathophysiology.
A diagnostic roadmap. Let's walk through it. Where does the investigation typically begin?
The most straightforward category is congestive splenomegaly. It's all about plumbing. The spleen's blood drains into the portal vein, so if there's a backup, like from cirrhosis causing portal hypertension or a splenic vein thrombosis, the spleen gets congested and enlarges.
And the imaging clues for that would be external to the spleen itself for the most part. You'd look for nodular liver, ascites, varices.
Exactly. But there are direct splenic findings too. The paper mentions Gamma-Gandhi bodies, which are classic signs of portal hypertension.
Right, those small cytorotic nodules. What's their characteristic appearance on MRI?
They're organized focal hemorrhages, so the hemosiderin makes them lose signal on all pulse sequences. T1, T2, gradient echo, they're just consistently dark, a very specific finding.
Okay, so if there's no evidence of congestion, what's the next branch in the decision tree?
The next logical step is to look at the clinical context and other imaging findings. The paper presents a great algorithm in its figure 10. Let's say the patient has significant lymphadenopathy along with the splenomegaly.
That would point toward two big categories, infectious or hematologic neoplasms.
That's right. For infections, a classic example is infectious mononucleosis from the Epstein-Barr virus. It typically causes diffuse splenomegaly without a focal abscess, often with widespread lymphadenopathy, especially in the neck.
And this is one of the conditions where you worry about splenic rupture.
Yes, rapid enlargement can lead to rupture. Other infections like malaria can cause massive splenomegaly. But generally for infections, you see diffuse changes rather than a collection you could drain.
Now, what about the other possibility with lymphadenopathy, hematologic neoplasms?
This is a huge and critical category. Lymphoma is a key malignancy involving the spleen, and its involvement can present in a few different ways.
What are the patterns?
The most common is just homogeneous splenomegaly with no focal lesions. Then you can have diffuse infiltration with tiny miliary lesions, multiple larger nodules, or least commonly a single large solitary mass.
Here's the key question, though. The paper states that splenomegaly alone is an unreliable indicator of splenic involvement in lymphoma.
It's a crucial point. About 30% of normal-sized spleens in lymphoma patients actually have tumor infiltration. Conversely, you can have splenomegaly for other reactive reasons without any tumor cells present.
So you can't rely on size. Are there more subtle imaging signs to look for?
Yes, and this is a great practical takeaway. The review highlights a couple of useful signs on contrast-enhanced CT. First, the obliteration of the normal transiently heterogeneous or zebra pattern enhancement of the spleen in the arterial phase. A lymphoma-infiltrated spleen tends to enhance homogeneously.
Okay, so a lack of that normal arterial pattern is a red flag.
It is. The second sign is a low spleen-to-liver attenuation ratio in the portal venous phase. Basically, the infiltrated spleen appears darker than the liver. Together, these signs are much more suggestive of lymphomatous involvement than size alone.
What about other hematologic cancers? Leukemia, for instance.
The imaging findings for leukemia are very similar. You'll see splenomegaly, lymphadenopathy, and sometimes these low attenuation miliary splenic lesions. The paper notes that differentiating these from fungal microabscesses on imaging alone is very challenging.
Which is where clinical context is king. Now, the paper also mentions myeloproliferative neoplasms. This is where we can see some truly dramatic splenomegaly.
We can. Conditions like primary myelofibrosis often cause massive enlargement. This is driven by something called extramedullary hematopoiesis, or EMH.
Define that.
In plain terms, it's when blood cell production happens outside of the bone marrow. When the marrow fails, as it does in myelofibrosis, hematopoietic tissues in places like the liver and spleen reactivate and expand to pick up the slack, leading to huge organ enlargement.
Got it. Moving on from neoplasms, what about non-malignant infiltrative diseases, the next category in the paper's framework?
Right. This is when the spleen is infiltrated by abnormal substances or cells that aren't cancerous. A prime example is amyloidosis.
The deposition of abnormal proteins. What does that look like in the spleen?
The key finding, besides enlargement, is reduced contrast enhancement on CT. The spleen just doesn't brighten up as much as it should. On MRI, it's a bit unusual, high signal on T1 weighted images and low signal on T2 weighted images.
That's a helpful set of clues. What's another big one in this category?
Gaucher disease. It's a rare genetic disorder where a specific lipid accumulates in the reticuloendothelial system, and it is one of the classic causes of massive splenomegaly.
How massive are we talking?
The paper cites one study that found an average splenic enlargement of 2,200%.
2,200%? That's hard to even picture.
It's an astronomical number. The spleen can fill a huge portion of the abdomen. Occasionally, you can see focal nodules as well, which can be hypodense on CT.
And then there's sarcoidosis.
Yes, the systemic inflammatory disease that forms non-caseating granulomas. Abdominal involvement is common, and it often presents as hepatosplenomegaly with multiple small focal lesions. Interestingly, these lesions are more frequently seen in the spleen than in the liver.
The case in Figure 4 is a great example. You see these fine nodules throughout the liver and spleen, plus enlarged lymph nodes in the retroperitoneum and chest. A very systemic picture.
Exactly. The next category the authors discuss is rheumatic diseases. The spleen is a key immunological organ, so it's frequently involved.
Like in systemic lupus erythematosus, SLE, or rheumatoid arthritis, RA.
Right. Splenomegaly is a common feature in RA, and there's a specific rare complication called Felty's syndrome, which is defined by the triad of seropositive RA, splenomegaly, and neutropenia.
And for SLE?
Splenomegaly is present in 10 to 46% of patients, and it's often more pronounced during periods of high disease activity. The authors show a case in Figure 5 where a patient with worsening abdominal pain has an enlarged spleen along with edematous bowel wall thickening and ascites, all signs of an SLE flare.
So the splenomegaly is part of a constellation of findings. This brings us to another major category, diseases related to the spleen's job of filtering blood.
The non-neoplastic benign hematologic diseases related to clearance of blood cells. It's a mouthful, but the concept is simple. The spleen's job is to remove old or defective red blood cells.
So if a disease produces a lot of defective cells, the spleen goes into overdrive and enlarges.
Precisely. This happens in conditions like hereditary spherocytosis, where red blood cells are abnormally shaped, or thalassemia, where they're fragile. The spleen works harder to clear them, leading to work hypertrophy.
What about sickle cell disease? That's a bit of a special case, isn't it?
It is. Early in life, the sickled cells clog up the spleen, causing enlargement, what's called splenic sequestration. But over time, these repeated episodes of vascular occlusion lead to multiple infarctions.
And the spleen progressively scars down.
Exactly. It leads to what's known as autosplenectomy, where the spleen becomes a tiny, fibrotic, non-functional nubbin. It's a unique evolution from splenomegaly to splenic atrophy.
The paper also mentions iron overload here. How does that fit in?
Patients with these conditions often require frequent blood transfusions, which leads to secondary iron overload, or hemosiderosis. The excess iron gets deposited in the reticuloendothelial system, the liver, spleen, and bone marrow.
And that gives a very characteristic MRI appearance.
A very characteristic one. The iron causes a profound drop in signal intensity, especially on T2 and T2 star-weighted images. The spleen and liver can look almost black. It's a nice differential to keep in mind, distinct from the signal changes in amyloidosis.
Okay, that covers a lot of the systemic causes. What about when the problem is intrinsic to the spleen itself, the non-hematologic neoplasms?
Right, primary splenic tumors. These can be broadly categorized as cystic or solid. For cystic lesions, the main one to know is lymphangioma. It typically presents as multiple cystic lesions that can replace a large portion of the spleen, as shown in Figure 8.
And solid lesions?
Among the benign ones, hemangioma and hamartoma are common, but the paper calls out literal cell angioma, or LCA, as a particularly interesting one.
Why is that?
Because unlike most benign solid lesions, it often presents as multiple nodules. This can be diagnostically challenging because multiple lesions raise concern for malignancy or infection.
What are the imaging features of LCA?
The authors show a case in Figure 9. The lesions are hypointense on the portal venous phase CT, but show progressive enhancement and become isoattenuating on delayed phases. On MRI, they are hyperintense on T2 weighted images.
But it's generally benign.
Mostly, though there are rare low-grade and malignant variants. That case in Figure 9 actually developed liver metastases 6 months later, which underscores the need for follow-up.
Yikes. So what about the overtly malignant primary tumors?
The main one is splenic angiosarcoma. It's very rare but extremely aggressive. It typically presents as large, hypervascular masses, often with necrosis, hemorrhage, and rupture, and it metastasizes early and often, especially to the liver.
And finally, what about metastases to the spleen from other cancers?
It's not the most common site, but it happens. Most splenic metastases are found in the context of widespread multivisceral disease. The most common primary tumors to spread to the spleen are breast, lung, ovary, colorectal, gastric cancers, and melanoma.
Okay, that's an incredibly comprehensive overview. It really drives home the point that splenomegaly is a nexus for a huge number of pathologies.
It really is, and that's why the diagnostic algorithm the authors provide in Figure 10 is so valuable. It helps organize this complexity.
Let's just trace a couple of paths on that algorithm to see how it works. If the key clue is an abnormal blood test,
The algorithm directs you to consider myeloproliferative neoplasms if hemoglobin or platelet counts are high, leukemia if the white blood cell count is up, or hemolytic diseases if hemoglobin is low but reticulocytes are high.
and if the main finding is, say, multiple nodules in the spleen?
It gives you a differential that cuts across all the categories we just discussed. It could be infectious, like an abscess, infiltrative, like sarcoidosis, hematologic, like lymphoma, or a non-hematologic neoplasm, like literal cell angioma or metastasis. You then use the other clinical and imaging features to narrow it down.
So the bottom line here is about integration. No single finding, not even size, is enough. You have to synthesize the clinical picture, the lab data, and the specific imaging patterns.
Exactly. The goal of this review is to equip radiologists to move beyond simply reporting splenomegaly and toward providing a meaningful differential diagnosis that can guide the clinical workup. It's about leveraging imaging to tell a more complete story.
And doing so with a focus on non-invasive and minimally invasive methods first to avoid unnecessary splenectomies.
Precisely. It's a very practical and systematic approach to a common diagnostic challenge.
That brings us to the end of our summary. Join us next time on SummaryCast.